Hello everyone. Thank you for joining today's 2019 QCDR Measure Workgroup webinar, Session 1 QCDR Measure Development webinar. The purpose of this webinar is to provide an overview of the Qualified Clinical Data Registry Measure Development process for Year 3 of the Quality Payment Program. Now, I will turn it over to Sophia Sugamar, Health Insurance Specialist in the Center for Clinical Standards and Quality at CMS. Please go ahead.
Thank you very much, and welcome all to today's presentation. Today, as stated before, is part 1 of 2 in a series of presentations specifically focused on QCDRs and QCDR measures. Today, as mentioned before, we will focus on QCDR measure development. We do want to put it out there that our key audience that we're looking to participate in this webinar would be those that are interested in becoming a qualified clinical data registry. And that might be a specialty society, a large healthcare delivery system, or a regional health collaborative. This is not a webinar where we would be discussing submissions. This is not meant for the individual eligible clinician or group. We just want to make sure that's clear so that we have the pertinent stakeholders on the call. And as we get to the Q&A towards the end of the presentation, we do ask that you keep your questions focused in on solely the QCDR-related items or QCDR measure-related items. Any other MIPS-related policy questions will be deferred, and we will ask you to refer to the Quality Payment Program Service Center, or any questions related to APMs as well will need to be referred to the Quality Payment Program Service Center. With that, I will turn the call over to my co-lead for the QCDR registry work, and that is Dr. Daniel Green. Dan, take it away.
Thank you, Sophia. Welcome, everybody. Thanks for joining us. If we could move, slide 2 is our disclaimer about the information contained in this presentation. Slide 3, just going to title it off here with our agenda and our objectives overview, and then if we could actually move and land on slide 4, that would be wonderful, please. Thank you. All right, so basically, we're going to talk a little bit about our strategic vision and our measure initiatives, particularly as they relate to QCDRs. We receive over 1,000 quality measures that are part of the self-nomination process from our vendors. Many of the measures are good, while other measures, are missing something that we're looking for or topped out or what have you. And we put on a program similar to this last year, and we're continuing to have it because we want to educate and communicate to interested parties what we're looking for in measures submitted through QCDRs, in the hopes that it will cut down on time put into measure development efforts that basically are not accepted in the program. We know there's a lot of disappointment when that happens, but we are raising the bar, if you will, on QCDR measures, and we are looking for them to not only be just like MIPS measures, but actually even be better than MIPS measures. So we will today talk about the QCDR measure requirements. We will talk about measure principles, measure structure, and then we'll also talk about some advanced measure concepts, which would be things like composite measures and multi-strata measures. There will be some resources listed at the end of the presentation, and of course, as Sophia mentioned, we will have a question and answer session. So I think that's it for my announcements. So we can certainly move on to slide 5, and I will turn the call over to Marla Throckmorton to go over some of the information in more detail. Thank you.
Thank you, Dr. Green and Sophia, for getting us started today. My name is Marla Throckmorton from the MIPS QCDR Registry Support Team. Our presenters today also include Stephen Shalega with the Quality Payment Program and Jocelyn Meyer from the MIPS QCDR Registry Support Team. Next slide, please. CMS has an overarching strategic vision which guides the setting of measure development priorities. The 4th bullet says that measures should address critical clinical gaps in care, support evidence-based medicine, and should engage patients as well as clinicians in care delivery. If you also pay attention to the last bullet. It talks about measures help consumers make informed decisions regarding their health care and choice of clinician, facility, and services. If you have seen or heard Dr. Verma, the CMS administrator, speak lately, she has really focused CMS's efforts on empowering the patient and ensuring that quality data is available to the patient as a consumer to allow informed decisions. This really should be considered when starting the QCDR measure development process. Next slide, please. This is a graphic of the CMS Meaningful Measures initiative. On the left, in the big blue circle, you can see that the patient is at the center, along with the CMS 4 strategic goals: improve CMS customer experience, support state flexibility and local leadership, support innovative approaches, and again, as we just discussed, empower patients and doctors. The CMS strategic goals connect to the 6 cross-cutting criteria, such as eliminating disparities and track to measurable outcomes and impact. These cross-cutting criteria are surrounded by icons that represent the 6 quality priorities that are shown in the right-hand column. One of these quality priorities, the top one, is promote effective communication and coordination of care. Within this priority are 3 meaningful measure areas, starting with the medication management. The quality priorities, as well as the meaningful measure areas, can really be crosswalked back to NQS domains. For example, the NQS domain of patient safety can be aligned with make care safer by reducing harm caused in the delivery of care. These meaningful measure areas can really help focus the measures that you are starting to develop. Next slide, please. Meaningful measures assess core issues that CMS considers most vital to providing high-quality care and improving patient outcomes. CMS intends to prioritize outcome-based measures and reduce the focus on process measures. The last bullet has a list on how to ensure that a QCDR quality measure can be considered meaningful. For example, the minimizing level of burden for providers. Next slide, please. We're now going to start diving into the QCDR measure development process. Next slide, please. This is the basic, these are the QCDR measure basics, and QCDR measures must have the following attributes that are listed there, which includes being a clinically intuitive, or the measure has to have clinically intuitive appeal or high face validity, which is simply stated whether the measure appears at face value to measure what it claims to. So this means by reading the measure description, eligible clinicians can easily determine the patient population and the quality action. It is clear what is needed to meet or not meet the quality action. Next slide, please. This slide further delineates the attributes as listed on the prior slide, such as evidence-based should be clinical guidelines or recommendations from reputable sources, as well as should be the most recent or within the past 5 years. As you go through this list, it's important to note that even a measure that focuses on or contributes to a better patient outcome does not necessarily mean that the measure will fit into the MIPS value-based payment framework, such as, or for example, measuring a never event like a fire in the operating room. It doesn't mean that this isn't a good measure or a good thing to be pursuing as far as quality. It simply means it cannot be scored in a way that fits the intent of the MIPS value-based payment program. Next slide, please. Jocelyn Meyer will now take over as presenter. Thank you.
All right, thank you, Marla, and thank you to everyone that joined today's work group. We are very excited to present this two-part series, which will concentrate, this series, our presentation will be more concentrated on the measure development, but we'll touch upon the expectations of QCDR measures. So next slide, please. All right, so this first slide is just a QCDR measures checklist for consideration. When constructing a QCDR measure, the measure should meet all of the following criteria. The measure should align with the measure development process as laid out within the blueprint. This is a very great resource and which provides concise measure specification guidelines that will be intuitive, as Marla had mentioned earlier, to the clinician. There is a link at the end of this presentation to this resource, and very encourage everybody to review that as well. The measure should be clinically relevant and based on evidence. It should reflect the most recent published guidelines. And this, we encourage you to provide a link or something within your self-nomination of the measure to support the measure and the guidelines. We encourage vendors to include evidence of a performance gap. If you've already started to collect performance data for the particular measure, it's highly encouraged this to be submitted within your self-nomination. Please include the average performance rate, the number of clinicians included within the performance data, and the range. That is very helpful for us when we're reviewing measures. We do provide feedback to QCDRs during prior self-nominations, or if the QCDR took advantage of a concept or measure preview call. There will be instances where we may provisionally approve a measure and provide a recommendation to either update the quality action or broaden the denominator, whatever it may be. If this is not completed, we'd ask that you would provide a rationale why it wasn't completed. And lastly, or the last two bullets, is focusing on the quality action instead of documentation. We review a number of measures that only look at, for instance, a documentation of a score, but do not have an associated quality action that actually assesses what that clinician is doing to provide quality or efficient care. And lastly, as well, you are well aware, CMS does prefer outcome measures over the process measures. To be considered an outcome measure, the measure should require some sort of improvement, or they met a guideline-based value of control. But we'll take a deeper dive into outcome measures later in the presentation. Next slide. When CMS and the PIMS team reviews the QCDR measures, we are expecting that they meet all of the following criteria. The measure should fall or align with the clinical workflow so that data collection is not burdensome. It should address one of the meaningful measure areas that Marla previously reviewed. The measure should be analytically sound and fully developed, and it shouldn't be in just the concept development phase. We do receive multiple submissions each year that when, for instance, if we request the data, they are unable to provide since the measure may not be feasible quite yet, or they're unable to pull the denominator or the numerator. These measures should not be submitted for consideration, as they do not provide performance data to appropriately score or drive quality care. They also should indicate accurate measure analytics, whether it be inverse or risk-adjusted, ratio, proportional. We will review these measure concepts in a couple minutes, but we stress the importance of appropriately categorizing the measure during self-nomination. We do expect that QCDRs have measure development experience and would be able to apply these concepts to their QCDR measures. In addition, we expect that all the QCDR measures and the components within have proper spelling and grammar throughout the QCDR measure specification, as this is a posted document on the QPP website. In addition, if approved from a previous performance period of MIPS, we ask that if there are any changes to the QCDR measure for the upcoming performance period, these substantive changes are identified, and if they alter the intent of the QCDR measure or may impact the score, a new measure ID will be assigned. Next slide. All right. On the other hand, we do review each of the QCDR measures to ensure that the QCDR measure is not duplicative of an existing or proposed MIPS quality measure. Measures being considered for MIPS for next year can be found on the CMS website. This is known as the MUC list. Vendors may also refer to the proposed rule when it is published. Additionally, measures should not be included if they are considered tapped out. This would be, generally this is above 95% or less than 5% for inverse measures. As a reminder, QCDR measures do not follow the same tapped out timeline as MIPS CQMs. In addition, if measures should not duplicate an existing QCDR measure unless there's a dramatic improvement over the existing measure. We do take a number of things into consideration when a duplicative measure is considered. For instance, does it fall closer in line with the guidelines? Is it a broader denominator? Is the quality action more robust? Maybe it uses a broader array of tools, but we ask that these measures are harmonized between vendors and QCDR measures that are similar in topic or concept, that these QCDRs would collaborate and submit one harmonized measure. And lastly, QCDR should not duplicate a retired PQRS measure or, for that matter, a retired MIPS measure. Next slide. In addition, QCDR measures should not split a single or related clinical process or outcome into separate measures. For example, results of 3 different tests are required for a standard of care. Each of the tests should not be create a single measure, but these 3 tests, if you will, would be combined into one and create a more robust measure. We also have seen measures that split an assessment collection into one measure, and another measure may address the plan of care to address the positive assessment of the other measures. So those types of measures definitely should be combined into one where there's an assessment and plan of care. QCDR measures should not have a potential of unintended consequences. For example, a measure that discourages an oncology patient from receiving oxygen therapy or comfort care measures. This has actually been submitted in the past, and consideration to those unintended consequences should be heeded. And lastly on this one, this slide is focused on the elimination of serious preventable costly medical errors. And Marla had stated earlier the never events. For example, the surgery performed on the wrong patient. While we agree this is important to avoid at all costs, but since they rarely occur, it does not allow for comparison across clinicians and groups. Next slide. I'll give it a minute just to catch up. There we go. All right, some general principles for QCDRs. QCDRs must be clinically relevant and harmonized and should align with the public and private payers, since MIPS QCDRs should include all payer data and they're not limited to Medicare. The measures should be minimally burdensome to report, ensure that measures are selected from the MIPS program to reflect the best available science, and may require retiring or revising from year to year to reflect the latest clinical guidelines. And lastly, just to mention, and you'll hear this a lot from our team, is CMS welcomes the opportunity for a measure concept call to meet with QCDRs to preview measure concepts prior to self-nomination. If you want to request that, a call, please see slide 44, and this will provide instructions in doing so. Next slide. We'll be diving into the measure structure. And we can go to the next one as well. Thank you. All right, here we go. Denominator exclusions, we just want to take a minute to identify the differences and the timing of how to apply these different measure concepts. So denominator exclusions refer to criteria that remove the encounter or the patient from the denominator before determining the quality action was completed or the population. Exclusions are more absolute, where the quality action is not applicable and should not be considered for the population. This would remove the patient prior to establishing the eligible patient population. After evaluating for the quality action, we would move to the denominator exception. These exceptions permit the exercise of clinical judgment and implies that the treatment was at least considered for the eligible patient, but there may be a medical, patient, or a system reason why the quality action was not performed or provided. Lastly, numerator exclusions. These apply to ratio or proportional measures for inverse proportional measures. And an example is this would be if the number of central line bloodstream infections per 1,000 catheter days were to exclude infections with a specific bacterium, that bacterium would be listed as that numerator exclusion. And as I had mentioned, these would be appropriate for those inverse proportional measures. Next slide. We'll take a look at a measure flow here in a minute when it pops up. This may be familiar to some, but the MIPS measures all include a measure flow following the measure specification. These provide a very helpful visualization and establish the eligible population and evaluate for the quality action. In the example, you would start with your age, if the patient met the age criteria, the encounter, and in this case, the patient was screened for future fall risk and there was 2 or more, you would then move to your denominator exclusion, which would be a hospice. If they met hospice, they would, and they were receiving hospice services during the measurement period, they would meet that denominator exclusion and no longer be eligible for the population or the denominator. And then once you establish the eligible population, you would move to your performance met fall risk assessment, and then if that for some reason was not completed, you would evaluate for the medical reason. And then, of course, if they didn't meet that medical reason, it would be a performance met or a missed opportunity for reporting. But we do want to stress that whole establishing the patient population and the timing of the denominator exclusions and whatnot. So I would highly encourage to take a peek at the MIPS measure flows because that's a great visual aid. Next slide. Following each of the flows within the MIPS specification, there are example calculations. Please note that denominator exclusions are not included within the eligible patient population. The denominator exclusions are included within the numerator of the data completeness as submitted instances. But to calculate the performance rate, denominator exclusions or exceptions are removed from the denominator. So just please note that the performance rate denominator is actually the data completeness numerator minus the denominator exceptions. And then you would take that number and you would be able to define the population within the performance rate. Next slide. When submitting a QCDR measure for consideration, you will be required to assign a measure type, whether it be process, outcome, efficiency, or structure. A process measure focuses on the clinical process, which may lead to a certain outcome. If the process is well executed, it will increase the probability of achieving that desired outcome. For example, a clinician asks about tobacco use and advises all tobacco users to quit. The likelihood of meeting this outcome would increase as they frequently ask about and counsel for tobacco cessation. Next slide, please.
Jocelyn, do you mind just as you're going through the slides, just mention the slide numbers so everyone's on the same page? Thanks.
Yep. All right, so we're on slide number 23, and we'll discuss the outcome measures. CMS is moving towards more outcome-based measures. They are measures that assess the results of healthcare that are experienced by patients, clinical events, recovery health status, experiences in the health system. Outcome measures are supported by evidence that the measure has been used to detect the impact of one or more clinical interventions. A MIPS example would be 191. This is looking at patients that receive cataract surgery, and following that cataract surgery, they achieve 20/40 or better visual acuity. So that positive outcome would drive that measure. So next slide, on slide 24, which would be efficiency and cost resource use measures. Measures of cost and resource use can be used to assess the variability of costs of healthcare and to direct efforts to make healthcare more affordable. Our MIPS example in this instance is Measure 102. This is ensuring that patients with low or very low risk of occurrence does not have a bone scan performed, because this population, it's not clinically necessary based on the studies. Next slide, 25. Patient-reported outcomes. They use patient feedback to determine the outcome. For example, you may have a pain or function improvement after a particular surgery. The numerator should require some sort of improvement. We've consistently rejected QCDR measures that only capture the distribution or the collection of survey assessments. So keep that in mind. There are a number of functional and pain QCDR measures currently, but our feedback to any QCDR that submit a measure that is just collecting surveys would be you have to show some sort of improvement, patient satisfaction, things of that nature. Next slide. And then we will actually transition from measure types over to the measure analytics portion. There are different methods of representing the measure's performance. First is the proportional, which is the most common type of measure analytics within MIPS. This has a traditional denominator, which would be considered the eligible population, and the numerator being the quality action. The performance rate of a proportion is calculated by taking the number of patients meeting that quality action divided by the eligible population included in the numerator of the data completeness. So example of that would be our MIPS 128. We're looking at a broad denominator and the quality action being that the BMI was documented, and if in normal limits, or had a follow-up plan if outside of those normal limits. Next slide, please. Transitioning into the non-proportional, this would be considered, an example of this would be a continuous variable. These can fall anywhere along a continuous scale. So for example, mean time to provide thrombolytics, This actually aggregates the time in minutes and from a case from presenting with chest pain to the time of administration. And the next slide, please. Lastly, we have ratio measures. These are not represented in MIPS currently. Performance can be calculated by dividing a count of one type of data by another type of data. Ratios are unique in a sense that the numerator is not found within the denominator. For example, the number of patients with central lines who develop an infection divided by the number of central line days. We could also take a look at the length of stay for heart failure. We could expect the length of stay to be 4.5, but the actual length of stay was 5.5. This would result in a ratio of 1.2. And rates closer to 1 would represent the expected outcome. And next, I am going to turn it over to Stephen for a few slides who will discuss some of the non-proportion scoring implications that have arisen. Next slide.
Hi, good afternoon, everybody. This is Stephen Shalega. So as Jocelyn mentioned, we're going to go over some of the different scoring implications associated with the measure structures that are outside of the standard performance. So non-proportion measures include a variety of different elements that could be captured as the numerator information. The variability makes the mathematical analysis unpredictable related to producing reliable benchmarks as the information contained within the numerator could be different. Some of the examples related to this would be average time in minutes, average time in hours, change in outcome related to tests, the length of stay, or the potential for a ratio where it's measuring expected over observed. In addition to the information above, you can also see that outliers can have a large impact on modeling if not realized and adjusted. If you have practices that are located in different physical locations, or the practice size is different, the general patient population, which we would not have, and also additional risk adjustment factors would play a large part of this variability, where you could potentially have some practices performing very low because of their physical location, or they have a large amount of high level of high-risk patients that are attributing to the overall score. Next slide, please. So one of the items that we've talked about before is the structure of these non-proportion measures and potentially converting them over into a performance measure by establishing a benchmark within the measure itself, as opposed to producing the continuous variable metric and trying to establish a benchmark based on the information that we're receiving. So, for example, you could always tie it into a time metric if that's something that you're doing. So if you're looking at something where the door to balloon time, where what's being reported is the mean time from arrival to balloon, you could establish the time at which you have deemed as acceptable within the medical practice and set that as the performance metric to measure against. So you could say all patients that were seen in under 2 hours based out of all patients that were seen, to give you a percentage that could be compared on a scale from 0 to 100, as opposed to a continuous variable metric that could be unbounded on both sides of the benchmark. Next slide, please. One of the items that we have done, as these are measures within the program, and there has been a request to benchmark these as part of the program requirements, is we created a new structure that can be utilized for reporting to give us a percentage that we can more reliably track against what is submitted based on the information within the measure. So you can see on this page that it is outlining the non-proportion type for reporting, and each one of the fields are writable within the submission object itself. So the reporting rate would be the percentage of the eligible population that is being reported in the numerator. For example, if you've seen 1,000 patients and you've captured the continuous variable metric that's being reported in the numerator on 700 of them, it would give you a reporting rate of 70%, and then you could report your numerator that you have captured. So if you're doing the mean time from door to triage or something similar to that, then you could report that information, and we can more reliably get a sense of what the reported population is, as well as being able to assess whether or not you're meeting the minimum data completeness thresholds established within the program. Next slide, please. And from here, I will turn it back over to Jocelyn.
All right, thanks, Stephen. Next, we'll look at a couple more of the advanced measure concepts and constructs. We can go to the next slide there. Slide 33. There we go. First, a composite measure. A composite measure is two or more of the individual performance measures that results in a single score. There are multiple methods of combining this data to maintain the measure's intent, as well as provide valuable feedback to your eligible clinicians. Composite measures provide an opportunity to assess quality of care over a broader and more comprehensive manner. Please note that denominator exceptions can be tailored to the quality action being measured. For example, a clinician providing optimal IBD care could provide comprehensive treatment, including multiple components, including a daily aspirin and tobacco cessation, but the contraindication for aspirin may be a GI bleed, but that really wouldn't be an applicable denominator exception for tobacco cessation. So just want to make sure that you keep that in mind when developing these more robust composite measures. Next slide. Slide 34. The first type of composite that we'll review is the all or none, which requires all of the quality actions to be defined within the measure to be completed in order to be counted as a numerator compliant for that overall measure. In the provided example, it requires controlled blood pressure, non-tobacco user status, daily aspirin, and statin use. QCDR measures looking at a particular disease process that split all of these quality actions into multiple measures. We would request that the QCDR combine into a composite prior to approval in order to make a more robust, comprehensive measure to address the diagnosis. Basically, we don't want or wouldn't want to approve a bunch of one-off measures. Next slide, please. Slide 35. And this is sort of on the flip side, it's the any or none. Based on the review of performance data, this would require all of the adverse events to be avoided in order to meet performance. So for instance, if a measure was looking at infection, wound disruption, mortality, readmission, you may combine these all into one measure, and if a patient breaches or meets any of those, you would actually fail the measure. Based on prior review of performance data, we've seen many of those individual complication QCDR measures that only take a look at one complication. The majority of these are tapped out, and sometimes extremely tapped out. In an effort to identify a gap, we would highly suggest to explore combining these individual complication measures to form a more comprehensive any or non-composite. you would still be able to collect that individual complication rate, but the eligible clinician would be scored based on the overall rate. Next would be the linear combination. You may combine an element into a simple average or a weighted average of the individual measure scores. And lastly, we don't have a whole lot of these, the regression-based. It may place a little bit more weight on a particular element of the composite. So say, for instance, 70% of the performance would be derived from the first strata or the first measure, and only 30 would be derived from the second component. All are very good options, but would encourage everyone to explore those. Next slide, please, slide 36. There are other opportunities to create multi-strata measures. Let's wait for it to catch up. All right, here we go. Multiple denominator options reduce the number of measures by addressing a single condition or quality action or topic. There may be a number of reasons for stratification, maybe age grouping, specific condition or location, different complications of the same procedure, vaccinations, or etc. Next slide. Within MIPS, we have a number of multi-strata measures. In the example provided is CAD, beta blocker prior MI or LVSD, less than 40. So this is stratified stratified by risk, and so it's going to split the denominator basically by patients who are 18 years and older with a diagnosis of CAD, with prior cardiac surgery, who either have a current LVF less than 40, and then on the flip side, they may, the second denominator looks for that prior myocardial infarction. So just a couple different ways. Both populations are appropriate for receiving that beta blocker therapy. Next slide. All right, slide 38, here we go. In order to score eligible clinicians appropriately, we would ask that if multiple performance rates are submitted, you would indicate how the overall rate should be calculated based on how the measure is constructed. A couple options would be a weighted average. This takes the numerator counts of each submeasure and divides by the sum of the denominator counts of each measure. As we just reviewed, as measure 7 is calculated by a weighted average. Another option would be to take the simple average, which adds the percentages for each submeasure and divides by the total number of component submeasures. And MIPS number 9, as the ECQM only, is an example of a simple average. Next slide. And lastly, we have another option for determining the overall performance would be the indicated performance rate. The measure steward would actually provide which performance rate should be used for the overall rate, and it should reflect the more robust quality action. A MIPS example would be 238. One measure looks at one high-risk medication, and the other is two high-risk medications provided to the elderly, and the eligible clinician is actually scored on the more robust provision of one high-risk medication, noting that this is an inverse measure. Next slide, please. Slide 40. We're going to transition a little bit towards the risk adjustment. All right, the aim of risk adjustment is to really even the playing field to assess outcome based on the patient characteristics and risks. There are a number of statistical models provided in the CMS blueprint. And statistical models should not include factors associated with disparities of care, as these factors will obscure the quality problems related to the disparities. So when you do submit a measure, we do ask that question if the measure is risk adjusted. Next slide. But we do want to highlight this risk adjustment is not the same as risk stratification. I think that's been a common misconception and indicated incorrectly on some of our previous self-nominations. So wanted to highlight that. Risk stratification separates the measure's denominators by risk factors. For example, the size and number of polyps maybe for a measure would determine the amount of time to monitor a patient, whereas fewer or smaller polyps would have a less frequent interval or follow-up, so that would just be a way of stratifying those two different risk populations but containing the information in one measure. And the blueprint provides additional great examples that include stratification by race, age, social risk factors, and income. Next slide here. And we're on slide 42. All right, a QCDR measure that is being electronically derived or data mined from an EHR, the electronic QCDR measure will still be benchmarked as a QCDR measure. We have had some conversations regarding this topic, but at this time, they will still remain under that one QCDR benchmark. EHR data mining is permitted without ECQM designation. We do want to encourage, if vendors do want to specify a measure, that they collaborate with the measure steward prior to creating of ECQM version of the measure. For example, identifying any SNOMED or ICD-10 codes that have already been in use. And these ECQMs or E-specifications must be tested and produce valid data and maintain the measure's intent. And as always, definitely be respectful of the copyright and the protected intellectual property. And that is all I have, but before I turn the call over to Marla to review some of the resources that we've been mentioning throughout this call, I just want to note that we are coming to the end of our presentation. So if you have any questions regarding the QCDR measure presentation, just make sure you place those into the Q&A. And next slide, Marla.
Thank you, Jocelyn. If you'll move on to slide 43, or 44 actually. I believe that there is a lag with the slide decks moving, so it'll be just a moment. So the next three slides are resources that are available to you to help start the process that you're working through. Here we go. So one of the resources, this is one of the first resources that we placed on the slide deck, is a resource that is highly encouraged for QCDRs or potential QCDRs to take advantage of, is the Measure Concept Preview Call. The preview calls can be used to discuss new measures under development, as well as used to discuss the information or actions CMS required for the provisionally approved measures from the prior performance period. You know, this is an opportunity to be one-on-one with the CMS and then the MIPS QCDR registry support team. So in order to place a call or schedule a call, you would send an email to the QCDR vendor support at gdit.com. There is a Google Calendar which will show the start and end date of the window available for requesting a call. You email that vendor support email and include 2 to 3 options of times available over approximately a 2-week period that can then be coordinated with Dr. Green and Sophia's schedule. You should also include the email addresses of all those from your team that you would like to attend. And then 1 week prior to the scheduled call, it is important to provide a single document listing with all the information, measures to be discussed. This really allows our team to analyze the information and then be prepared for a more meaningful dialogue in the time that we have allowed. The Google group is also a tool that's available. The Google group is also a tool that's available that can be used to foster communication and collaboration between the QCDRs. It's really a tool for QCDRs and not for CMS. It's just a way for you to have an opportunity to speak to others. Next slide, please. The next 2 slides really just include the different types of resources with the links. For most of the information that Jocelyn and Stephen and I presented, one is for the blueprint for the CMS Measures Management System. There's a National Quality Form Measure Evaluation Criteria, Measure Development Plan, etc. The CMS Resource Library also has additional reference materials which will be updated this spring for the 2020 performance period of MIPS. And then on slide 46 is some resources when you're doing e-specified or electronically specified quality measures. So now we can move on to the question and answer portion of our work group.
Okay, great. So we'll be taking questions that came in through the chat. So if you have any questions at all, please drop them into the chat. We'll start working our way from the bottom through the top. So the first question comes from Rory Letvin from the American Board of Family Medicine. The question is, for some provisionally approved measures, suggested harmonization has been recommended. 1, have all parties been notified of the suggested harmonization? 2, how do parties contact each other? And 3, are there incentives for the organizations to work together?
I can help with that. During the self-nomination process last fall, when you received or when QCDRs received approval or provisional or rejection notices from the CMS PIMS team, we did provide the feedback to harmonize with the similar QCDR measures. So they should be knowing that this is a request. The parties can contact each other. We do provide contact information on the qualified posting. That you can find their contact information and start from there. And the incentive is that the measure will be approved moving forward as one harmonized measure instead of, if you submit this in a subsequent year and we've asked that you harmonize in a prior self-nomination, it would likely be rejected, or we may just choose the better measure or the measure that we feel is more robust, or the items that I had mentioned before where maybe has a more broad denominator or uses more assessment tools, things of that nature.
And this is Sophia Sigmar. Just to add to Jocelyn's answer, if you are having troubles reaching specific points of contact at the specific QCDRs we've asked you to harmonize with, feel free to reach out to us, the QCDR vendor support email inbox or the PIMS team, and they will provide you with specific points of contact that work on the QCDR itself. In some instances, the qualified posting might point you to a more general email, and so we've had QCDRs come back to us, so that is also available. We are open to giving that information as well. And then in terms of another incentive, having a harmonized measure in the program means that it's more likely to be benchmarkable, that it will reach case minimums and therefore have more than 3 points applied to the measure. In instances where the QCDR measure is not being able to reach a benchmark threshold, it is only it's only available for 3 points for a clinician to report, which is why we encourage harmonization as much as possible. And also it's counterintuitive to our program and the Meaningful Measure Initiative to continuously have duplicative measures in the program. So if harmonization doesn't occur and there's no strong rationalization as to why the harmonization didn't occur, we would reject all the measures that were not harmonize and either select the more robust of the group, or the measures would not continue to move on in the program as duplicative measures. So we do encourage harmonization to occur, and we will send reminders accordingly prior to self-nom starting that this should be something that the QCDR should be working on.
Okay, and a follow-up also from Rory. How is harmonization communications initiated?
So once CMS gives you, or the PIMS team provides the information as to which QCDRs we'd like you to reach out to, we'd expect the QCDRs to reach out to one another to begin that discussion. And again, in instances where you're not getting their answer back, please let us know, or if you need specific points of contact, if you're not hearing from others, that is good information to provide. We would like to see that there's an actual effort made on your side to pursue this harmonization effort.
Okay, so from Rebecca Hancock, we have her question, which is, can a measure evaluate an outcome that is achieved outside of the calendar year? For example, for a measure that looks at an outcome 90 days after surgery, this limits measurement to surgeries that occur before October. Is there a measure structure that could account for this so that all surgical outcomes can be evaluated?
Yeah, so from a MIPS measure standpoint, we have a couple of different, and I think as you know, we have a couple of AAO measures that shorten that performance period to allow the clinician to evaluate the outcome, whereas there are other measures in the MIPS program that have a index period. So I'm referencing the depression remission measures where actually they look at denominator eligibility prior to the performance period to establish that diagnosis so that they can assess for depression remission within the performance period. So we'd want to make sure that that quality action is within the performance period. And Dr. Green, if you have anything to add on that one, feel free.
Okay, moving into the next question from Laura Springer. When is the call for quality measures to be considered in the MIPS program?
Good question. It is actually coming up here tomorrow where it opens up and will close on June 3rd, I believe. Sophia, if you have any updates, or Jennifer,
nope, I believe that's correct. I haven't heard otherwise, but it will start tomorrow and go till June 3rd.
Okay, next question from Hiran Dave. Why doesn't CMS share a list of complications, in parentheses gaps, that CMS wants improved with statistic data? This could serve as guidance for QCDRs. There's a couple parts to this, so if you want to answer the first part, and then I can move into the rest.
Sophia. Do you know if we have any of that data available to us at this time? I'm not sure if we do, or maybe Dr. Nilasina.
I'm sorry, what data?
It says, why doesn't CMS share a list of complications that CMS wants improved with statistical data? The only thing I could think of is the...
So we don't share specific reports with statistical data that outlines gaps. What we do have that indicates where there are measure development gaps are the CMS Measure Development Plan and the CMS Blueprint. Those are both measure-related documents that kind of go through the different areas of measure development, but also cover areas of measurement gap where we're looking to have more measure development in. So I would utilize those documents if you're trying to figure out what areas you'd like to pursue measure development in.
Okay, moving into the next question from Kathleen Bowman. She wanted to confirm that a measure at 95% or above is considered topped out by CMS.
Correct, for non-inverse, and this would be only applying to QCDR measures. We do take a number of different performance data into consideration. We'll take the 2019 performance, benchmarking performance, any MIPS data that was submitted into consideration in addition to the QCDR provided data. So all of that will be taken into account when reviewing a measure.
Okay, next question, also from Mihir and Dave. Why doesn't CMS create a level of importance scale for quality measures in the MIPS program instead of just asking providers to report on 6 or 7 measures? Measures should be reported by importance based on goals the government wants to achieve.
Thank you for the feedback. We had previously in, I believe, the 2019 rule solicited comments on a similar type of setup. So we are taking that feedback into consideration. Thank you.
Okay, from Lori Lackey. Is MIPS physician or hospital incentive payments? When does the incentive payment begin?
Could you repeat the question, please?
Sure. Is MIPS for physician or hospital incentive payments? When does the incentive payment begin?
So MIPS is a physician and group program. If a clinician earns an incentive, they're typically paid 2 years after the reporting period. So for 2019, any incentive earned would affect their 2021 reimbursement.
Okay, moving on to the next question from David Graff. How do errors and omissions and fair and accurate disclosure work with respect to QCDR measure development?
Errors and omissions, and what was the other part of it?
And fair and accurate disclosure work.
I'm not 100% sure I understand the question because, you know, if we're talking about reporting, that's one thing. If we're talking about measure development, which is what I thought you added at the end, I mean, the measures, as they're developed, we expect them to be evidence-based is certainly preferable. If not, you know, we expect there to be some science as well as strong, consistent expert opinion behind whatever measure, whatever it is we're measuring, be it if it's a process or, you know, there should be data to support a particular outcome measure. So not sure about the errors and omissions as it relates to this process. I mean, we'd certainly expect the measures to be checked by measure experts before they're submitted to us.
Okay. And then the last piece that we have here is more of a piece of feedback. It comes from Karen Davidson. As a follow-up to Rebecca's question, the frustration with a look-back period is that there has to be an encounter with the patient in until performance period. This is challenging for specialists, particularly surgeons who don't always see patients for long-term follow-up.
Yeah, Karen, definitely I can appreciate that challenge. I would definitely suggest taking advantage of that measure preview concept call, and maybe we can discuss and try and mitigate some of those challenges to develop some of the more outcome measures that you're referencing.
Okay, and as a reminder, if anyone else has any questions, please make sure that you're typing them in the Q&A chat, which can be found on the left side of the screen. We have a question from Florencia Whitehead. If the focus is outcome measures, will the required one outcome measure will be increased? And if the focus is outcome measures, will the required outcome measure be increased?
The requirements for the quality performance category, as they stand right now and for 2019, is that clinicians are required to report on 6 quality measures, and one of them must be an outcome measure. And that's the extent of it. There's
anything else would be enrolled.
That's exactly what I was going to say. Thank you, Dan.
See, we think alike. Poor Sophia.
Okay, we'll stay on for another few minutes to see if there are any other questions that come through. Here we go. From Amy Davis, can you relieve the expected timeline from initial submission through hopefully approval?
Are we going through that, Jocelyn, at the next webinar?
I believe for the, I would have to check with Anastasia, but I think that's on the support calls for current QCDRs. But for for vendors that are not currently a QCDR, I guess we could do a very high level where self-nomination actually starts July 1st and ends September 1st, I want to say. And then in the subsequent weeks following that, we do a measure review. And there's also self-nomination that would look at your vendor submission as well. And then, I mean, I can't give you certain dates that you would have an approved measure or a rejected measure for that matter, but it's in the weeks or the month following, you would know that if a measure was approved or rejected following the close of self-nomination. Hopefully that helps.
Okay, we have a question from David Graff. Can we illustrate claims reporting and claims occurring process with respect to voluntary and involuntary events associated with QCDR?
I don't know, Sophia, I might need more information regarding this one.
Yeah, if the person asking the question can provide more clarification, it might help us figure out what we're trying to answer here.
Well, we'll give it a minute to see if we can get some more clarification. And if anyone else has any questions around QCDR measure development, again, please make sure you put it in the Q&A, and we'll be sure to read it out loud and respond. Sophia, do you want to talk about the second QCDR webinar that's taking place real quickly?
Sure. So the next webinar, which is part 2 of this series, will happen next Tuesday, March 5th. And it will be focused specifically on criteria to be a QCDR in and of itself, and then also criteria in terms of measure approval, what we're looking for, measure decisions, why we make certain decisions the way we do. And so we're really trying to raise the bar on our QCDR measures and our QCDRs as well. So we thought it would be important to share that information so there is some time to level set expectations and what we're looking to have in our program as we move forward. So there will be a lot more detail in terms of what we expect from QCDRs in order to qualify to become a qualified clinical data registry. And then we will spend, I believe, the second part of the presentation going through the actual measure decisions and why we make such decision points. That will be the focus of the second half of this series. And we thought that it would be best to break this up so that people can get an understanding of what we look for in terms of the measures, in terms of structures, and the different criteria of the measures before we actually get into the review and approval process of the QCDRs and their measures. I think we have a question coming in.
So we did get a follow-up from David, which is, are the claims reviewed by the committee reviewed on a claim reported or claim occurrence basis?
I don't think that question is pertinent to the QCDR discussion here.
Yep. So
I don't even understand it either. So, but it's we're limiting our questions to the measure construct and topics.
Yep. So, David, we would suggest that you go to the QPP Service Center. Someone will contact you directly through the platform to provide you directions of where to go.
If there aren't any more questions, certainly don't want to keep folks on the line just for the sake of it. So,
Dan, I think we have a few questions that came in.
Okay. Okay.
So, Ketchum, there's one from the American Board of Family Medicine. Did you want to read that one?
Absolutely. So this comes from Rory. With the shortened self-nomination period, the ability to create measures and collect data is shortened. Given that shortened period of time exists, it will be more challenging to get data to populate these provisionally approved measures. Given this is the first year of the shortened period of time for the self-nomination, will this be taken into consideration for provisional approval?
Yes, I think that certainly we will take timing into consideration, considering we've just wrapped up 2019 self-nom in December, and now we're preparing for self-nomination to begin for 2020 in July. So if you do not, on your provisionally approved measures, have performance data to share, we would ask that you ensure or provide clinical evidence that that shows us that your measure reflects the most current guidelines and current studies, and that will help us as we review your measures. But that is certainly something we've kept in mind in terms of requests for data or harmonization. The time frame in which self-nom for 2019 has ended, and the timing of when self-nom starts in 2020. For 2020, that is.
But the other caveat to that is, at the same time, QCDRs have known that we were moving to this this earlier self-nomination for about a year now, because I think we announced it in the previous rule. So would want folks to kind of be mindful of that, where if the measure is very questionable and there can't be data to support it, it may be precluded, with the caveat that it could be re-self-nominated if there, in the future, if there is shown to be a true gap.
Okay, it looks like we don't have any more questions coming through. So, Sophia, would you like to close the call, the webinar?
Sure. Why don't we give it like 2 minutes just in case someone else has a question, and then we can close it up.
Sounds good.
And I'll defer to Dr. Green to close the call.
Gee, thanks, Sophia. All right, last call for questions, folks. Anything come through, guys?
I think we can wrap it up.
Sounds good. Well, we appreciate everyone's interest and participation in today's call and for the thoughtful questions. We will look forward to speaking with you guys soon on the next part 2 of the call. And in the meantime, if you do have issues or questions, if they're generally MIPS related, please do write into the Service Center. And if they're more specific to QCDRs, you can certainly start at the Service Center, or you can send them to us through the mailbox. We'll look forward to speaking with you soon, and hope you have an enjoyable weekend. Thank you.
Thank you. This concludes today's conference. You may now disconnect. Speakers, please hold the line.